Well, welcome everybody, and welcome to everybody who's online. I know I had trouble finding this place again, so we'll probably have some stragglers coming in still. Just a couple of housekeeping items, reminders that the QR codes are on the doors here. Those are QR codes for the evaluation, so you can get credit for CME and CNE and whatever other CEs there are. And also, we'll be going through some slides at the beginning just to talk about any conflicts of interest, which I don't believe there are any. And finally, for those who are online, please do not use the chat, but instead use the web, what's it called again? The Q&A section on the web webinar that'll be available at the end. And also, please try to hold the questions for the end unless the speakers invite some questions. Well, it's my great pleasure as the academic chief for the Division of Medicine and Psychiatry to introduce our three speakers today, who are going to be talking about our newest med psych unit, also known as G92, also known by its acronym. So I'll start on the right-hand side and make our way down to the right-hand side of these folks over here. Kirk Harris attended Penn State's Medical College for medical school and completed a dual residency in internal medicine and psychiatry at Rush University Medical Center in Chicago in 2012. After working as a consult liaison psychiatrist at Rush and leading the department's psychiatry's safety and quality board, I believe, he joined the medicine and psychiatry division in the summer of 2021 to help us open and to lead the 10-bed med psych unit on G92. He and our nurse leaders paved the way for what is now called the Summits, Substance Use, Medical Management, Infection Treatment, and Support model on the unit. Next to Dr. Harris is Becky Harper, who graduated from St. Lawrence University with a bachelor's degree, and shortly after pursued a master's degree in mental health counseling. After working in the mental health field for a few years, she went back to get a nursing degree from SUNY Brockport's accelerated nursing program. And it was during that experience that she completed a capstone on Unit 19200, our med psych unit, and started working as a new nurse very shortly thereafter because she really enjoyed the work that was being done there. And very rapidly, by 2022, she took on a new role as assistant nurse manager and more leadership role on the Summits unit. And all this while pursuing an NP degree. And in fact, this week she started as an NP on our inpatient units. So that's exciting to see how her career has grown with us. And finally, Robyn Wohlers is, last but not least, is a certified alcohol and substance use counselor, or CASAC. Lots of acronyms today. She comes from a background of working in supportive living and outpatient programs for the Wayne County Behavioral Health Network and the Finger Lakes Counseling and Recovery Agency, or FLACRA. And she started her training to become a CASAC in 2018 and soon put her skills to use as part of the Strong Recovery Substance Use Disorders in Primary Care, or SUDPC program, adapting its goals to the inpatient medical side by joining the Summits unit. And she continues to work as a liaison between Summits, other medical units, and in the hospital and SRCD. So I'm super excited to introduce this team, and I'll let them take it away.
Okay, in October of 2021, we last did a Romano rounds introducing the Summits unit. And at that time, we described mostly the development and building of the unit because we'd only been open 3 months and didn't have a whole lot to say about how it was going to go. So we really appreciate the opportunity to be able to update that for everybody. Okay. Mostly our objectives are to update what we've done since then and to make sure everybody's really familiar with our great unit. And nobody pays us for anything interesting. Okay. My part of the talk is, again, a reintroduction to the unit for anybody who wasn't around for the last one or who wants a refresher. And I gave most of this at a national conference a couple of weeks ago. So starting out by introducing med psych at University of Rochester, most of you are probably very familiar with that already. In the med psych community, it's a really big deal, the extent to which we have a well-established, really robust med psych apparatus. So we have our primary care clinic at MIPS, and most people are familiar with the IMIPS unit on 192, which provides in-hospital care for people with serious mental illness. And the story of the Summits unit is that around 2018, institutional leaders challenged the med psych leadership to come up with a population to expand and open 10 additional beds. At the time, it seemed relatively straightforward what population works for that, because 2018, we were in the middle of the opioid epidemic, or at least in the middle of public interest in the opioid epidemic. I think most people would agree we're still in the middle of the opioid epidemic. And, you know, it was really obvious there was a lot of national attention on it. There are a lot of people in the hospital for long infections from opioid use disorder. And it was clearly the worst thing that was going to happen to the medical system really ever. And so we began planning, I wasn't here. Our nursing leadership and med psych leadership began planning out how to open a med psych unit that would serve the needs of people hospitalized for long infections and complications of substance use disorders. These are slides about endocarditis that I included last time we talked, and they show through the immediate period up until the planning of the unit what was going on with, in particular, endocarditis related to substance use, growing as a proportion of endocarditis infections. Really, the endocarditis on the graph on the left, light gray is endocarditis not related to substance use. It appears to be rather steady over time. And the portion related to substance use, which classically we would teach as maybe 20% of endocarditis, was growing and growing. In that graph, 2018 was not a particularly good year. It was just only partially completed when they put the graph together. And then on the right, a graph showing heart surgeries for endocarditis related to substance use. And in particular, the focus there is that the very risky repeat heart surgeries appear to be increasing over time. And mortality after heart surgeries, especially the repeat procedures, is extremely high. Surveys of addiction treatment in hospitals demonstrate that most people receive very little. This is from a study of, again, surveys of endocarditis related to substance use. And these are relatively low rates, I think most people would agree, of consultation to addiction or psychiatry services. Only 11% were receiving medications for their use disorder, and a really substantial amount of discharge planning was either absent or didn't include any plans for substance use disorder. Half of all patients were readmitted relatively quickly, and 26% of the patients looked at in this study died. Average age of death for those patients was around 41 years old, and most of them within the first year after their admission. So the Summits unit opened with a plan to begin to provide patient-centered care for substance use disorder, to try to reduce some of the system's barriers to arranging follow-up and appropriate treatment, and in particular to reduce patient and staff distress related to the care around infections and substance use disorder. Most patients in our population will tell us directly that they feel they're often not well treated in the hospital, they're not well understood, and they, for many reasons, many systematic and many intrinsic, consider self-directed discharge at a rate that's not surprisingly high, but is very high. part of the goal in unit design was to try to create a space that feels good to be in, that doesn't look entirely like a hospital. And these are from these are an ambitious architect's idea of what in hospital space could look like, early rendering. And honestly, we didn't do that badly. These are early images from just before we opened up. And I got to tell the national conference, I really wish I had current photos to show you, because it looks a lot more livable and nice to be in now than it did at the time. And for this talk, we do have more current images to show you. So it's a 10-bed unit on the ground floor of the hospital. We're staffed by a full-time physician and an APP working as the medical team. We have 2 RNs and sometimes 3 now with a charge nurse most of the time, drawn from the pool of med psych RNs who also staff the 192 unit. We have a dedicated psych tech, a social worker. We have initially a team of CASACs rotating through, and now Robyn specialized to be on the unit full time, and peer support specialists. And the focus of the slides here were to describe some of the innovations to the national group that we were doing. Patients are identified for the unit through a proactive process that involves screening in the electronic health record through an automatic list that shows us people with infections and substance use diagnoses. And then we process those along with referrals from the toxicology and infectious disease services. We found it's most helpful in many cases for our CASAC to interview patients before they come down, both to prepare them for the unit and to assess what their needs are and their interest in participating. And then on the unit, we have really a remarkable number of activities, including daily recovery groups, individual counseling sessions for those who need it. Our peer especially initiated the collection of big supplies of clothing and art supplies and entertainment, and some initiatives around wellness sessions, and the Memorial Garden, which is outside G92, that many of you may have seen coming in or out of the building. Like our 192 sister unit, we have daily interdisciplinary rounds with a large team on every patient every day. And this table identifies some of the usual roles of each team member in contributing to patient care. And we tried to develop over the past couple of years initiatives around the bigger challenges on the unit. And this says education and harm reduction, really could say challenges and lessons learned. These are the things that we have had to really work on as we developed into a functional service. So pain management is very difficult in patients with substance use disorders. Initially, when we were planning the unit, we had the idea that we would try to avoid chronic pain patients on the unit, where chronic pain was the primary driver of their opioid use, and they potentially didn't have the behavioral elements of an addiction. And in our effort to think about that and make the distinction, what I think we overlooked a little bit was that many of our patients with opioid use disorder were going to wind up having really substantial pain anyhow. The number of patients who enter the unit after a trauma or a surgery are quite large. And as I understand it, open heart surgery is not particularly comfortable in the immediate moment or for a little while afterwards. Spinal epidural abscesses and osteomyelitis are a large number of our patients, and those as well are not particularly comfortable most of the time. And in retrospect, it's not a surprise that most of our patients have waited until the condition becomes extremely painful prior to coming into the hospital for their lengthy stay. And they may have had more than one presentation to the hospital previously when the condition was a little less severe and not been able to maintain a stay in the hospital. Our other substantial challenge has been around patients' autonomy and travel off of the unit. On most medical units, this is pretty routine. Patients come and go, will wander down to the cafeteria or other areas of the hospital. And given our location and the concerns around harm reduction and patients' impulsivity and substance use, we had to really develop an approach to how we were going to handle patient autonomy in a way that reduces the risks of self-directed discharge and allows people to feel like they're getting good care in the hospital without being punitive or too restrictive. This is a view of the wellness garden when it was nice and in full bloom and warm. I think everybody here works at URMC for the most part, so you know that this photo was taken when it was actually warm outside, right? You can just tell. Okay. So where have we been in the last couple of years? Well, data collection for the group of patients on our unit has been a little bit challenging. We estimated in the planning process that 10 beds was a good choice for a couple of reasons. One, that 10 beds was what we had available to develop, and but secondly, a survey of the hospital suggested we probably have between 10 and 15 patients in the hospital at any given time that would be eligible for the unit. Although since opening, that's not always been the case for reasons that include both the medical complexity of the patients, a potential decline in the eligible population as a whole over time. And so there are times when we're looking for patients that don't match our immediate population. So as we draw on data out of the electronic health record, we often have some difficulty differentiating between the patients who were on the unit as general medical boarders or short stay patients with substance use and those for whom the unit was designed, those people who'd be in the hospital for a really long period of time and be connecting to follow up after a long stay. In total, we've had 618 hospitalizations or so. This data is drawn from around September of this year, and a little over 500 unique patients. We've manually tracked our substance use population to the extent that we're able. We're still developing that data into a cleaner form. And in that area, we have about just under 500 hospitalizations and just under 400 unique patients. You can see there's a suggestion here that most of the patients in our total population with more than one admission, those 69 patients, are probably also substance use patients because we have at least 59 of those who've had more than one stay on the unit. Our length of stay is long. That's good. Our admission criteria require for our CASAC patient an estimated length of stay of more than a week. And so we'd be disappointed if we had less than that. And coming in with an average of 17 days for our substance use patients looks pretty good. And our patient population is quite a bit younger than the medical hospital as a whole, with an average age of around 42. One of the pieces of data we wanted to look at first around the unit was how are we doing in terms of matching expected demographics. And so it was important to us at least that the patient population on the unit match the surrounding county. And I think we have done a reasonable job there. You can see on our age graph, we have a very young population overall. I'm going to guess that most of the patients over about 70 are general medical patients that we added in to help fill beds and decompress the emergency room when we did. And then beyond the admission data, we were looking hopefully to develop improved follow-up and improved adherence to medications. So we wanted to look at the characteristics of the patients in terms of substances used and their willingness to take medications and to follow up. Most of our patients use more than one substance on a regular basis. And excluding tobacco and marijuana, I think our numbers for marijuana probably aren't that great anyway, because a number of patients won't mention it as a substance use because they don't consider it a substance use problem. We have a substantial amount of opioid, alcohol, and cocaine use in our admission population. Cocaine use the highest, which felt a little surprising to me initially. In retrospect, after reflecting, I don't think really is a big surprise. These numbers obviously don't add up to 100 because of the multiplicity of substances used. And medication efforts, I think we did better. It was in the endocarditis study initially, it was about 11% of patients left the hospital on medications for opioid use. I'm pleased that we've done somewhat better with roughly 90% of our patients obtaining medications for opioid use. Our alcohol use patients, you might say we're at a somewhat lower number who obtain naltrexone or acamprosate. And in thinking about that, we had to consider what was happening there. So it's worth noting that roughly 30% of those patients also have opioid use and are taking medications for opioid use disorder. So naltrexone is certainly off the table for anybody on buprenorphine or methadone. I think the other thing that we're seeing happening there is many of the patients who use alcohol are dual cocaine use at the same time and consider cocaine to be the major issue for them. And so don't necessarily consider alcohol to be something they're looking for treatment for. And after discharge, we have two relatively rough methods of looking at where patients go. The left table is from our electronic health record, and this is the disposition that accompanies the discharge order. If you can tell me what most of those things mean, then you know more about what's going on than I do. A large number of our patients go to inpatient substance use treatment. I can't tell you which one of these or which several of these account for that. On the right, we have numbers on our manually tracked substance use population. And so these are entered by our substance use treatment staff. And so these are somewhat more accurate, although limited necessarily. And we have still a substantial number who leave the hospital with no identified treatment or just referrals to treatment, but good rates of connections to outpatient treatment, and roughly a quarter going to an inpatient substance use treatment facility. I think one of the things that we've expected for the patients who stay longer on the unit is that substance use inpatient facilities sometimes become unnecessary. And so the higher rates of outpatient follow-up may actually be a sign of success for us. I'm going to hand off here to Becky, who can talk a little bit about in more detail about the development of the nursing culture and nursing protocols.
Okay, well, hello everyone, welcome. So my name is Becky Harper. I've been one of the assistant nurse managers on 192 and G92 over the last 2 years, with a focus on G92, working on policy, procedure, and overall how are we educating our nursing staff on this really unique population. So like Dr. Harris mentioned, he wanted some updated pictures, so here we are. So it does look a lot different than when we first started, a lot less sterile, a lot more homey. We kind of have followed this living room environment model. Obviously, it's a little bit decorated for Halloween too, which is kind of nice. We added a bookshelf. Patients are here for a very long time. They need things to do. So these are all donated arts and crafts, books, clothing, all of that. And here's just another view for you guys to see. So this is where our groups are held as well, and patients are welcome to hang out in here and spend time with one another in a milieu environment. So summits, where are we now? It's really hard to describe what our unit is when anyone asks, oh, as a nurse, where do you work? It's very, very challenging to describe what we do on G92, but I think the biggest thing that we do, we're a medical surgical unit. So as nurses, we identify very much so as med-surg nurses. And so every patient will often have the central lines, the IVs, they'll require wound care, pretty extensive. And then on top of that, we have the co-occurring SED diagnosis. So what we also are able to provide for patients is we're able to work them through detox. So we kind of have some elements of a detox clinic, which often are just in the community or occurs in the ED, but sometimes it occurs on our unit as well. And I think we're pretty well equipped at handling that. We sometimes do it better than some places. And then lastly, we work as a inpatient substance use treatment facility as well by offering these groups that I don't think there's another medical unit anywhere that offers substance use groups held by our CASAC, by our peer support specialist, and we have a senior psych tech who's designated to run these groups as well. And while we have been developing, like, what are we, what is our, what do we identify as? We've kind of been using these four facets of our culture that we're providing on our unit, and I'll kind of go more in depth into those. So as we have transitioned from all of our nurses on 192 and G92, and obviously you guys all know 192 is inpatient medicine and psychiatry, and the feel and just the type of nursing that we're providing can be a lot different than what we're providing on the Summits unit. So number one, I think just accentuating the importance of the harm reduction model that we have been imposing in terms of meeting patients where they're at is the most important piece. These patients come in, we're kind of catching them at a time. They're not necessarily coming in to the emergency department to focus on their substance use. We're really just catching them at like a moment in time where, hey, like, we have this to offer for you. What do you think? Or maybe they express to one of the consult teams in the ED that they're interested in recovery and going inpatient. And that's when we're able to kind of take advantage of that, that moment. And harm reduction, I think it's important to just exemplify that this is really just aimed at reducing all the negative consequences that come with use, not judging the patients in terms of their substance use and looking at them as a whole and doing anything we can to just reduce the harm that's caused by substance use. So a lot of the times, even if the patient is deciding to leave, maybe against medical advice or patient-directed discharge, we're sending them home with naloxone and just trying to just keep them as safe as possible. Another aspect of the care that we're teaching and just really promoting on the Summits unit is patient-centered care. We do this all the time on 192, treating all the symptoms that the patient is coming in with, looking at them as a whole, but then also just really encouraging patient autonomy and decision-making and their priorities. Patient priorities often do not align with our priorities. We all know this. We all work in psychiatry. So I think just accentuating, hey, where can we meet? Can we meet somewhere in the middle? Does this patient really need that 6 a.m. blood draw every day of the week? Could we space it out to 3 days a week? So just really working with the patient to find where we're both comfortable and just keeping them safe ultimately. Advocacy is another facet of our care. Continuing to educate all the other services across the hospital is super important. On Summits, we deal a lot with like the infectious disease team. We deal a lot with cardiac surgery. A lot of the other med-surg units, we get transfers from them. And I think it's important that we continue to just work on reducing that stigma that we sometimes face with this patient population and just continue educating them. And lastly, from a nursing perspective, I feel like the therapeutic alliance that we develop with these patients is huge and the most crucial in order for us to make any progress with these patients. A lot of these patients, like Dr. Harris mentioned, really have an extreme mistrust of the medical system, not just here at Strong. They'll talk about wherever they've lived, they've really struggled with connecting with providers and the teams that they meet here in the hospital. So I think just developing physical and emotional safety is one of the things we really focus on. So like I mentioned, all of us nurses, we would float between 192 and G92. On 192, I feel like the way we conduct nursing is a lot more traditional. We're really focused on like the individual patient, what they need, kind of task-oriented care. Whereas on G92, there's a lot more to it. These patients are ambulatory, they're independent, they are all interacting with one another in our milieu setting. So what we have to take into account is the individual patient needs, but also the unit and the group needs as well. So looking at it from like a physical, emotional, and social perspective, individually, we're doing everything a typical med-surg nurse would do that we would do on 192, but then we had to expand it and teach our nurses what else do we need to be managing. So in terms of the unit and the group needs, we talked about the physical space, how we created this living room model for the patients, where we have like the books, trying to help them rediscover some of their hobbies, activities. A lot of these patients have been deep in their use for many, many years, don't even remember what their favorite food is. So just kind of reinforcing that these things are very important and it's okay to try to discover these things. Emotionally and in terms of working towards their recovery, we have the groups that are run by our CASAC, our peer, and our senior psych tech. We were able to get 12-step programs to come to the unit, which was huge. These are just a huge source of support in the community that a lot of the patients really benefit from as they are discharged back into the community after their hospitalization. And then lastly, just managing that social connections between other patients, that's been huge. So as nursing, that's where I think one of our biggest learning points has been, is just how do we manage all 10 of these patients at once? Some of them know each other from the outside, so just learning how what we can do about that and how we can keep everybody safe. So moving forward, just talking about best practices and nursing education as a whole. We all know about the cycle of change, but we just really continue to reinforce that with our nursing staff. Relapse is a part of this cycle, so just reinforcing that to our nursing staff. We talk about it in care planning at every day, where we meet as an interdisciplinary team. We talk about which stage maybe the patient's at. Are they in pre-contemplative? Do they feel a little bit more in their preparation stage? And then also patients coming back in after a relapse, and not showing like any shame towards them about and just welcoming them back and kind of trying to pick up where we left off or seeing if we need to do something different this time. Pain management, I think, was another aspect of nursing care and education that, like Dr. Harris mentioned, this is a very, very challenging population to manage pain for. So as nurses, that's been a huge struggle for us. But a lot of education and a lot of emphasis on it's okay for the patient to ask for their pain medications. We can just help them to work through this in order to reduce a lot of their cravings and also for relapse prevention as well. We have the availability of our counselor now and a peer support specialist, which we've never had before. 192, they offer a lot of different treatment planning, different approaches to how they talk to patients, and then a lot of dispositions that nursing had never heard of before. So just teaching them about like long-term what some of these options might be for patients. And then some of those tangible skills, like just taking care of PICC lines, central lines, these are things that are very, very imperative to nursing care, and keeping patients free of infection and preventing central line infections has been huge. And then also these patients are all independent and want to be involved in their central line care. So kind of teaching them how to keep it clean, how to keep everything sterile in order to prevent like a prolonged or even longer hospitalization. And then lastly, I'm going to talk about managing in-hospital substance use, because this is something that is a struggle throughout, not just our hospital, but throughout the entire United States right now. 1 second. So obviously, like I said, this is a problem everywhere. According to the American Society of Addiction Medicine, 34 to 41% of patients that are admitted with injection-related infections have used non-prescribed substances during their hospital stay. So that's a lot, especially if we have 10 patients, that's 3 or 4 out of the 10 that could potentially be using substances while they're on our unit and admitted to our care, which feels unsafe, frankly. So what can we do about that? So this was one of the biggest challenges that we have been working on addressing with our nursing staff, and how do we manage it. But first of all, let's think about, why does this occur? Why are patients using while they're in the hospital? a big piece, according to the ASAM, is just to prevent withdrawal. Patients are terrified of going through withdrawal, boredom, sadness, maybe loneliness, untreated pain. And a lot of this is due to poor support, poor pain management, and then it can lead to ultimately patient-directed discharges or AMAs. So what's the biggest thing that we've done? We've tried to normalize that this is going to happen because this is the population that we're working with, but also we have been validating the emotions of nurses because it can be scary, it can be frustrating, and it can be really challenging. So just acknowledging all of that, I think, is super important for our nursing staff. Trying to reframe it in a way of, if we determine that a patient is using while they're on our unit, what can we do about it? How can we keep everybody safe? What can we do for the patient? What can we do to reduce your cravings, or your use or your pain, or what's going on? And ultimately, the patient has the autonomy to leave if they are just not ready and this isn't their time, and that's okay too. So what do we do? How do we maintain unit safety? First, we had to teach our nurses how to identify in-hospital substance use. So what we're looking at is what nurses are good at. We're good at checking vitals. We're good at acknowledging changes in clinical status, but also just kind of acknowledging if there's paraphernalia in the room. Sometimes visitors might be an issue or a struggle. And then also what's been really helpful for us is that we collect urine tox screens or UTOX screens at least once a week, ideally twice a week. So that way we can monitor patient changes in their levels, whether it's their fentanyl level, their opiate level, we can get a buprenorphine level too. So first was just learning how to identify that this is occurring. Second, how do we respond? So for nearly every patient, we have a naloxone order as needed. So that way we can use it for patients if we suspect that they've been are possibly overdosing or their respirations are really slow and we have concern they might be using. We'll continue to monitor that clinical status, whether it's with vitals, direct observation, and then obviously incorporating all members of the interdisciplinary team, whether it's the provider, or other support staff, et cetera. And then finally, how do we prevent this? So what can we do better? So continuing to treat those physical and emotional symptoms, the UTOX screens, like I said, 1 to 2 times a week is key. And then just involving all of our team members, I think, is most important because we need to be able to create a treatment plan that the patient is on board with and that we find to be safe and effective for this patient's care. So as we continue to grow, we have many opportunities, and I think continuing our education for our staff on how to communicate therapeutically with this population can be very challenging. I think a lot of the times we just aren't taught how to talk to this population. We know how to be very like therapeutic and empathetic, but sometimes we just really have to be kind of get down to their level a little bit and talk just in a way that they understand and they want to be heard. Also just continuing to provide education to other services about summits, reducing stigma, and then just continuing to involve community supports because recovery cannot occur in a vacuum. It cannot just occur here. It has to occur elsewhere and externally. So all these other offerings, like 12-step programs, recovery, all of these things. And then lastly, which I know Dr. Harris wants to try to get eventually, is hospital to hospital transfers. If we can get patients who are appropriate for our unit from Highland or Thompson or even RGH, that'd be really, really neat. And so finally, this is just what I want to leave you with. I can't read this because I might get too emotional, but I'll let you guys take a minute to read it. But I think we can look at the data, we can look at all the numbers and everything, but there are certain patients that just stick with you. And so I'll let you take a minute to read that. So just, in my opinion, final thoughts, we become nurses because we care. And I think patients like this are a reminder of why we do what we do. And just to be able to see the humanity behind each patient, each diagnosis, I think is most important. So thank you. And next I'll bring it to Robyn. and she'll talk about managing mental health in the medical care.
Hey everyone, my name is Robyn Wohlers. I am a credentialed alcoholism and substance abuse counselor. I'm just gonna go over real quick some of the things that means and what I do in my job. So CASACs we're able to complete initial substance abuse assessments. That includes determining level of care and providing diagnoses. With the level of care, what we do with that is we look at where a patient might fit best in treatment. So we have outpatient, inpatient, medication-assisted therapy, and residential treatment, supportive living. There's a lot of options for the patients. So we kind of help patients decide where they're going to go or what might be best for them. I also advocate for patients. I can provide family services and Narcan trainings. Specifically on G92, I do groups Monday through Friday for 1 hour a day, focusing on substance abuse themes. So that could be coping skills, triggers. We did a bunch of mindfulness at one point. We've been doing self-sabotage. So it just kind of provided the patients with different, I call them units. So we work for like a week on different skills, and then we move on to the next skill building. Because patients are here for quite a long time, so we can put these skills into use and practice while they're here. I also go throughout the hospital. I think Dr. Harris said this a little bit, and I assess patients for G92, but I also connect patients to treatment that are not coming to G92, and I will get into that in all the different units that I go onto, but that is one of the other things I do while I'm here. So my main job is help to coordinate care with other members of the medical team, providing outside resources and getting patients connected to treatment. So I'm out of strong recovery. My team is SUD-PC, that stands for Substance Use Disorder and Primary Care. We are a mobile unit of addictions professionals that can be utilized throughout the U of R system. We provide consults and assessments for patients to reduce the gaps in care, delays in care, and we attempt to prevent readmission into the hospital while supporting providers and providing efficient use of limited resources. My team gets referrals from all of the primary care offices in the U of R system, as well as our accountable health partners, which is a group of 40 rural primary care offices. And then we get all the referrals for the hospital. So if I can, I go to see a patient, I do an assessment, we call it an initial assessment, and then I will get them their follow-up appointments with Strong Recovery. They may already have an outpatient provider, so I will get them their appointment for that provider. The unique thing about Strong Recovery is we are one of only 2 methadone providers in the area, the Rochester area. So that is something that we take into consideration when we're doing this. A lot of people would like to be on methadone, but that requires a little bit of a process. So it's one of the things that we work on. And I just want to mention too that my outpatient counterparts also go to, they can go to their primary care offices. So we literally physically travel. I think, not to call Ben out, but we went to the home visit the other day because we couldn't get a patient to us. So these are some of the departments I go to. The emergency department I see a lot of. I see a lot of the solid transplant unit, cardiology, neurology, and then I haven't in a long time, but we used to get a few OB patients, and then obviously my home base is on Summits. So I just wanted to provide this model to kind of show what the concept of SUD-PC is. It kind of shows how our referral process goes. We are an access to care point, which means that we do the first steps for patients to get into substance treatment. So that we have one other team in strong recovery, and they get all the other referrals. So that's like probation, inpatient care. We are just primary care and then the hospital. So that's what this looks like, our system here. All right, so the unit opened 2 years ago. Dr. Harris mentioned we had a rotating system. That got to be a little challenging, holding an outpatient caseload and then trying to also coordinate care within the hospital. So about a year ago, I offered to come here by myself full time. I just really like the atmosphere and the pace of everything. I like working in high stress and challenging situations. So some things I've noticed, some positives that I've noticed are just a great collaboration of care. My team is wonderful. They've gotten on board really quickly with what we have to offer in the, integrating the behavioral health with the med surge, and they have adapted to everything we have asked of them. So they've done a really good job of that. I think we've seen a higher utilization of services, and I'm saying, people coming in to get their antibiotics, people accessing substance treatment while they're here. The staff I work with have been willing to try new things with us. Our strong recovery people have come into the hospital. I do believe we've increased retention rates, so people are staying for their duration of their antibiotics where normally they would have left. And then we saw the numbers connecting to treatment. That's a big deal. People are getting the help they need. They may not have come here for treatment, but they realize that now this is an option. And now the word's kind of gotten out, and they come in here knowing that we are a safe place for them and they can keep trying to get it. So also having me here by myself, I feel like has increased patient rapport. I get to know these people. It's basically my caseload for the 2 to 8 weeks that they're here. And it just helps with collaborating with care and getting them through those stages of change. So some challenges, I feel like we could use some more collaborative training. And what I mean by that is there are trainings that I have as a therapist that MedSurg does not. Motivational interviewing, unconditional positive regard, solution focused we did this past year. That would be great if we could all learn those things to better help our patient population. So I'm going to kind of put these two together: correct use of services, and then differentiating roles and scope of practice between CASAC and peer. And also sometimes I get called to see patients that I don't maybe necessarily need to see, like they're already connected to treatment. Sometimes you just need to maybe get a little more information from them and make those appointments. I can definitely help and offer support to the people who maybe don't know how to get those appointments, but just making sure that when I am called that it is, I am doing the connecting to services. And we've been talking about a little bit more time for me to get stuff rolling for people. And then staffing, which I think is across the board for everyone. So, and that's all I had. I think so. And then if you guys want to get a hold of us, my supervisor's here with us, so that's her main information, and then mine is at the top. Oh, this is I just want to, because we didn't talk about this. So we have patients paint these rocks for people who have maybe passed on, and then they're put in the memorial garden as our piece. They can memorialize their whoever it is to them. Do you have questions? I'm supposed to leave that, right?
Questions from anybody in the room?
Hi. Yeah, so my question, I guess, is maybe for Dr. Harris. I was looking at some of the information you were sharing about medications. Have you pulled any data or looked into, I guess proportionally, who ends up with like sublingual buprenorphine versus like an injectable medication, or you see sort of pros and cons of injectable over other types of medications? I'm just curious about your thoughts about the various methods of administration.
Yeah, the injectable medications we would want to consider are a long-acting form of naltrexone, Vivitrol for alcohol use disorder, and rarely for opioid use disorder, and injectable buprenorphine, which is trade named Sublocade. From our data doesn't include any of the injectable forms at the moment because we don't have either in hospital formulary. We know from both anecdotal experience and what's in the literature and what patients tell us repeatedly over and over and over that the injectable options are in many ways superior, and many people would prefer to leave the hospital on them. But as our data goes, all of the buprenorphine is sublingual.
Is there a goal for that we're able to work on getting? I'm sorry, follow-up question. Is there a goal to think about getting those in hospital formula?
There's an aspiration. I can tell you that many, this is not unique to University of Rochester, and many of our colleagues at other institutions provide injectable long-acting medications on the day of discharge, essentially by ordering them from an outpatient pharmacy, smuggling them, not smuggling, but bringing them into the hospital, having them verified by hospital pharmacy, and then injecting them before the patient leaves. And that is the only way that many institutions have found to solve this particular problem.
I think I saw a question over on the side.
Hi, Mark Nichols. It's not really a question, it's really just more a shout out for the creativity of how these things have been developed over time. It's really been marvelous. In fact, the unit is marvelous, and SUDPC has been wonderful in my clinical role in the liver transplant program. There's a lot of folks with alcohol issues. The idea is how can we help folks get better? They come here to get better, right? It's not about stigma, it's not about judgment. And we folded in the SUD-PCT now. Ben Curry, helping on the outpatient side, Robyn on the inpatient side. So really helpful to try to get these folks engaged at a point they're here to get care, get them locked into treatment, or hopefully locked into treatment early. So anyway, just a quick shout out to the creativity, the adaptability for you all.
I think we try to call that, we refer to that as the captured moment. So we have patients in our system that it should just be sitting here, only getting medical care or only getting psychiatric care. That's really the goal of this whole division. Yes?
So I have two questions. One is, I know the stay slide had very mixed population. You said some just medical, some definition long, but I'm curious how many patients are coming for the full course of IV antibiotics actually completed, because if you anticipate, I don't know if it's still 6 weeks, that's still very short. The average length of stay of common barrier is to complete that. And then my other question was, what medications are you using to treat the
So the question of how many people complete their course of antibiotics, I would love to have a hard data number for that, but it would be extraordinarily difficult to establish. The simplest reason for that is that often the duration isn't decided until it's decided, until it's either over or repeat imaging has happened or some other option. So we often can't really say what a full course is as much as we'd like to at the beginning of treatment. Another reason that becomes challenging is something I didn't mention in when discussing the challenges of why it's harder to fill the unit than it might have been anticipated to be. And that's that dalbavancin has become available as a long-acting antibiotic that allows people to receive an infusion and leave the hospital. And so I think the plurality of our patients probably have part of their antibiotic treatment in the hospital, and then part of their antibiotic treatment outside of the hospital using that method. there of course is the possibility for some patients that they'd skip the hospital entirely with dalbavancin, but there are a lot of mostly anecdotal at this point reasons that we would say that that would be detrimental. That there's a substantial amount of recovery in emotional and cognitive and behavioral factors that occurs over the first probably 2 to 3 weeks of hospitalization. That's kind of vital to being successful. And I think there was a second part of your question.
Cocaine.
Oh, right. Cocaine use disorder. I have to give credit to our toxicology service, who has really settled on topiramate as their favorite option for cocaine use disorder. I'm naturally skeptical by nature, and so I did look into literature for that before biting to it. And I would agree that topiramate for cocaine cravings probably has about the best evidence that's in the literature for now. That wasn't really good enough for me because the best evidence in the literature is pretty garbage still. Small studies, often open label. It's hard to blind topiramate versus placebo, right? People know when they're taking topiramate because they get side effects. So to supplement that with anecdotal evidence, I have asked as many patients as possible who agree to take topiramate whether they think it's helpful, and the responses have been generally positive. I think 1 or 2 patients have said no, not at all, and many patients have been very enthusiastic about it being helpful. So I'm marginally convinced.
Do you have a question from people online, from Robert Goldstein? Is there any information available regarding how this program is seen by the rest of the medical center?
Yeah, I'd love to put that into context by asking Marcia or one of our 192 IMIPS alums to describe how IMIPS is seen by the rest of the medical center now, how many years after it's opened? And I think that with a program like this, there's a need to have fairly constant education because perceptions elsewhere will sort of develop on their own over time about how a program works or how it's useful. So as anticipated when we opened, I think we're constantly working with a perception that we are an outpatient program or only able to take patients who no longer need hospitalization, when in fact the opposite's true, or an inpatient rehab of some kind or a psychiatric unit of some kind. And we need to constantly remind people we're an acute care medical unit for people who need to remain in the hospital.
It's an important opportunity.
Yeah, and that is the kind of thing the experience from 192 has shown just needs to be repeated over and over and over because people will, left to their own devices, develop their own intuitions.
Do you have anything to add to that, your experience with going to the other medical units and talking to them about?
I guess I would say people seem to, they're constantly calling on me to go, so I would assume that's a good thing, right? So, it's definitely a need that's being met. I don't want to say finally, but this is a unique opportunity for patients and for providers. So I think that I haven't heard really negative things, only maybe that I am one person, I can't do everything, and sometimes things have to be done in a certain time frame. But I would say that my services are being utilized consistently and constantly, and the more the word gets out, the more that grows for me. So I would say that it's been positive. I would hope that our, what people are describing it as, but I do think there are a lot of misconceptions as well. So we're just trying to continue the education about what we do, and what I do is vital.
Thank you, everybody.